Good morning. My name is James Wilson. I'm a clinician and I'm now 1 year into my DPhil with the Infectious Diseases Data Observatory. Philippe Guérin is my principal supervisor, and I'm looking at the application of individual participant data from clinical trials in the development of prognostic research in the theme of visceral leishmaniasis. So a little bit of clinical background, some context, also known as Kala-Azar, VL, or visceral leishmaniasis, is a neglect tropical disease. It's a parasitic disease transmitted by sandflies. Approximately 50,000 people suffer from this disease per year, with the worst burden in East Africa currently. Without treatment, death is very much the norm. The treatment's often toxic, hard to come across, and even with treatment, clinical outcomes can be poor. Mortality and relapse are about 5 to 10%, worse in some scenarios. Why are we interested in developing a prognostic model in VL? Well, it affects people in extreme poverty, people with access to very constrained resources. So being able to allocate those resources in an equitable way can improve outcomes. So we can help, for example, allocate high-risk patients to hospital beds, to antibiotics, to more kind of different treatments. So prior to developing a new model, two key questions must be asked. Firstly, does a similar model exist already? In which case, can we validate it and update it with our data? And secondly, do we have the right type of data? Do we have enough data to use to build the model? So to address the first point, that's my first slide. We, like all good DPhil students, did a systematic review of the currently available VL prognostic models, looking at all clinical outcomes. We identified 12 different models published in 8 studies. They all look at mortality. They don't look at treatment failure or relapse. They all look at mortality, and the vast majority are from Brazil. No studies from India. So, with our data, second question, what data do we have? We have, thanks to our incredible curation team, we're mostly sitting at the back there, we have over 9,000 individual patient data from all continents. Mortality is about 2%, which is quite a lot less than you would expect. These are clinical trial patients mostly. Relapse is about 4 to 5%, which is what you would expect. And we have variable signs, symptoms, blood tests from across the treatment. Given the lack of existing data on relapse, and given the high numbers of relapse in our data set, this offers an exciting prospect for how we can use our data. So currently, we continue to review our data, review the predictors we have and the outcomes. We're reviewing the methodological techniques that we're using, and we're collaborating, most importantly, with VL stakeholders across the world to try and create a clinical impact.